right. Welcome. Good afternoon. Just waiting for people to join. So we'll give about a minute or two. All right. We're about 1 minute in, almost 12:02. So I think we'll go ahead and get started. Welcome, everyone. Hello, my name is Jordan Thibodeau. I'm an associate director of research at the Kathleen Babineau Blanco Public Policy Center and also head of the evaluation team for the Whole Health Louisiana program. Now, I want to tell you we're very excited to welcome to you to our Lunch and Learn for Whole Health Louisiana. WHL is a collaborative effort led by the Louisiana Department of Health as the public sector anchor and funder for the Whole Health Louisiana initiative. And the Blanco Center leads the plan's implementation and evaluation. If you're unfamiliar with what Whole Health Louisiana is, Whole Health Louisiana is the state's cross-sector initiative intended to systematically address, mitigate, and prevent childhood adversity within our systems of care and support. WHL has four priority areas and goals: collaboration, awareness, workforce, and prevention and healing. With these priorities in mind, WHL's vision is to build a state where children, families, and community members across Louisiana are healthy and thriving, regardless of who they are or where they live. Now I'm going to turn things over to Quinn, our moderator for today's session, and introduce our speakers. Thank you, Quinn.
Thank you, Jordan. Hi, everyone. I'm Quinn. I'm a research associate here at the Blanco Center and the cross coordinator for the Whole Health Louisiana project. I will be moderating today's webinar and our future webinars for this season, along with my colleagues here at the Blanco Center. So, as part of this initiative, we are holding a variety of different activities meant to raise awareness and deepen conversation about trauma-informed care practices. Our virtual Lunch and Learn series touches on the workforce priority area of the WHL plan and features presentations from industry professionals and subject matter experts. Our planned webinars are all listed on the Eventbrite page that you all use to register for today's event. So before I introduce our speaker for today, I want to first mention our ASL interpreter for today is led by Lisa Gill. You should see her pinned onto your screen to view the interpretation throughout today's webinar. In addition, if you are attending for CEU credits, please do remember to complete the post survey at the end of today's presentation to receive your credits. Okay, with that being said, I'm going to introduce our speaker and presenter for today, Julie Foster Hagan, who was appointed Executive Director for the Louisiana Department of Health Rural Health Transformation Program in August of 2025. She helped lead the state in completing the application for this $50 billion program, and this effort included multiple opportunities for outreach and stakeholder engagement to identify initiatives and strategies with the most sustainable impact to improve healthcare outcomes for rural Louisiana citizens. She has worked for LDH for over 27 years in various leadership roles, including Assistant Secretary and Deputy Assistant Secretary for the Office of Citizens with Developmental Disabilities, Administrator of the Northlake Supports and Services Center, and Program Manager of the statewide OCDD Resource Centers. She was also on the Louisiana chapter of the AIDD and was recognized for her work on the Louisiana Historic Recognition Project, noting that she helped transform the field of intellectual and developmental disabilities in Louisiana. She served as a member at large on the board of directors for the National Association of State Directors of Developmental Disabilities since 2022, and she has been serving as a member of the NASDDDS National Policy Work Group since 2019. She earned her Bachelor's of Arts and a Master of Education in Speech and Language Pathology, as well as a Master's in Business Administration in Healthcare Administration from Southeastern Louisiana University. And with that, I'm going to hand it over to Julie to begin her presentation. And Julie, just let me know when you want to start advancing your slides.
Sounds good. Good afternoon, everybody. Give it a second to get started. So thank you for that great introduction. And super excited to share with you guys some of the great work we have going on at the Department of Health, as well as other state departments, because we have a lot of work that we'll be doing together as we look at moving forward rural health transformation program. You can go to the next slide. So super exciting for us. Oh, there you go. So big news. We were able to secure $208.3 million for Louisiana related to the Rural Health Transformation Program. That's just for year one of our program. And so we do anticipate if we get a similar amount over the 5 years of this grant program, it'll mean over $1.4 billion for Louisiana to be able to make difference for health for our rural residents. We were one of the top awards in the nation, so super proud of the work that that happened. We had a lot of engagement with rural partners, with healthcare partners to inform what we included in our application, and we do feel like it will make a difference. Our overall goal is that we want to make sure that every rural Louisianian has the same high quality health and health care as anyone else in the state. And through this 5 year investment, we're building sustainable access to care so that rural communities can thrive, both today and for generations, not just for the period of the grant. You can go to the next slide. Where this money comes from is the Public Law 119-21, which was the budget bill, the federal budget bill, allocated $50 billion to Rural Health Transformation Program. It's a really unprecedented grant opportunity. And the way that they divided that funding out is 50% of it went evenly to all states who applied and were approved. It was not, territories and districts were not available. So it was just the 50 US states, all 50 applied and all 50 were approved. So half of that money was allocated that way. The other 50% was based on how rural a state is, some data metrics, policy actions that we had, as well as the quality of the application. The other interesting thing about this grant is that it is, we only know how much we get in year one because we will have to do a report every year that shows where we are. We had to establish milestones that we would accomplish for each of our initiatives. So we'll have to report on where we are with our milestones. We will have to report on our outcome metrics. We will have to report on the funds that we have allocated. And based on that, each year, they will give us a new budget allocation. So they will compare us to ourselves. So did we do what we said we would do in our application? But then they will also compare us to other states. And so it's my goal that we do as best as we can. So then we potentially can get even more than that $208 million each year. Okay. So why is this important to Louisiana? It's important because we know that at 44 of our 64 parishes are either fully or partially rural. So over 29% of our Louisiana population lives in rural areas. And at the same time, when we look at the data, we know that in many areas, but especially in heart disease, diabetes, obesity, as well as tobacco use, we see a much higher prevalence when we compare ourselves to our rural areas compared to our urban areas. So, even more critical that we have efforts to address health and healthcare in our rural communities. Okay, next slide. We also know that almost our entire state is in what we call a healthcare professional shortage area. Our HRSA or HRSA takes a look at this by primary care, by behavioral health, and by maternal health. There is a link here if you'd like to go look at additional information, but we just focus this one on primary care. Although our grant will address all of those different activities, but we know that we are in care deserts, even with the most basic of primary care, almost in every parish across our state. So it's important that we have some focused efforts there. Okay. So some key timelines in terms of how we got to this point. It was in early August when the what they call the One Big Beautiful Bill Act passed. And so it highlighted in the One Big Beautiful Bill Act, that's where they said that this $50 billion opportunity was going to be made available. They put the grant under Centers for Medicaid and Medicare Services, CMS. A lot of the other grants we see in rural health come out of the CDC or out of HRSA, but this particular grant is out of CMS. And so CMS was then required to write rules and regulations and get out to states so that we could apply for this opportunity. In the budget bill, they said here's the $50 billion, and they required that CMS let states know how much funding we're going to get by December 31st. So there was a very short turnaround time. So from the point in time that that CMS made the announcement, they call it a notice of funding opportunity or a NOFO. From the time they made that announcement to the time that we had to turn the application in, it was only a 6-week window of time. So we had to quickly gather as much information as we can, gather as much input. We were only able to do 3 community idea raisers, but they were very well populated. Where we did one in the north, central, and south, where we got our community members, invited people to come to a town hall, and we just said, hey, we have this opportunity. Where do you see the gaps in care? Where do you see your concerns? We put together a 64-member task force from all varieties of different stakeholder groups and areas. We had pharmacy, we had ambulance services, we had grocery stores, we had all of our usual healthcare partners, all with a seat at the table with helping us figure out what are the best strategies or what are the most needed strategies that we have in our state. We also did an RFI, some of you may have seen and responded to. So where we are right now, we've submitted our application. We got our award, as I said at the beginning. We know that we have $208.34 million to spend in budget year 1. But what was required from CMS is that we go in and do modifications to our budget narrative, which we have completed and submitted to them. And they now are in the process of reviewing those updates and will make determinations. So we're hopeful that any day now we'll get an updated what they call a notice of award that tells us when we can start drawing down some or a portion or all of the funds, so that we can then start to make more announcements in terms of the investments that we want to make. CMS has also let us know that They are still in the process of reviewing. So I'm going to share with you the strategies that we have in our application, but just a note that there could be changes to these because they are all still subject to CMS review to make sure that they are they're within the guidelines of what they call allowable use of funds and unallowable or limitations on use of funds in the grant itself. Okay, next slide. So we have key investments, and a lot of this you sound like things that you guys talk about on a regular basis. We have key investments planned in the areas of workforce, technology innovations, innovative care, sustainable access, and make rural America healthy again. So I will explain to you. We have 6 different initiatives. We have 20 different funding strategies. And I'll give you kind of a snapshot of what we mean by each of those. The time frame, that's probably the biggest question I get is when can we expect to start seeing these funds make their way into our communities? And the answer to that is it depends on when we have CMS approval and when we can get some of those to be able to start getting these funds out. So the first initiative I'll talk to you about is a Rural Hero Grant. Some of you may be familiar. A couple of years ago, the legislature allocated funding for something called Hero Grants, which are partnerships with teaching institutions and healthcare institutions to help build workforce capacity, healthcare workforce capacity. When we looked at that, a lot of times our rural areas were not receiving those funds. So we will have an expansion on the Hero Grant program, but these funds will be used specifically for expansion of workforce in rural communities. We will also be establishing a rural clinician credit bank. This is what we call a state matching. So the provider or rural facility will put up some of the funds. The state will then put up some funds. And that's to allow the rural facilities to pay sign-on bonuses or retention bonuses to staff. We've heard that we know a lot of our larger institutions or larger hospitals or clinics are able to support large sign-on bonuses for doctors or nurses or even folks doing their billing and coding and but the rural facilities don't always have that extra capacity to do that, so we want to be able to give them that the ability to have that incentive with a state match for that clinic credit bank. We also will be requesting the legislature. We will not be able to do this year because it's not a fiscal legislative session, but we will be asking in 2027 to re-implement a state income tax credit program. We had this in place in years past, and over a 3-year period, we were able to see that program grow to where there were over 400 clinicians. It applied to doctors and nurse practitioners who were able to get an income tax credit for working in rural communities with a commitment to staying in those rural communities for 5 years. Unfortunately, that tax credit sunset, and it didn't get denied to revisit it. It just didn't come back. So we want to bring that tax credit program back, potentially with some modifications. We've had folks ask us about adding other clinicians for consideration for that tax credit. So that will require legislative action, but we will be working to move that forward in the 2027 legislative session. We are also planning to have investments in new education and training pathways. A lot of our universities, especially those who are closely connected to rural areas, told us that we all know that there's a nursing shortage across Louisiana. Pick an area, any area, there is a nursing shortage. But what our universities told us is that they have more students that are qualified and could go get into nursing school than they're able to support. So the idea here is that we help to have funding for a university or teaching institution. Doesn't just have to be the university level because this can be healthcare and the different types of healthcare professionals. But it would be having the ability for that teaching institution to add faculty so that they could support more students with a focus on students who are willing to work in rural areas, and also partnering with the rural facilities and potentially having some of the funding go to the rural facilities. Because what we heard is in order to do a residency or a rotation or a fellowship or an internship in a rural hospital or health clinic or area, there's resources that are needed for that facility to be able to support that, whether that's staff supervision time or other things. And so these grant funds could be used that would go to the facility, and they're partnering the teaching institution and the partnering rural healthcare facility to be able to grow additional pathways for more students to get trained. Okay, next slide. Continuing, we have probably more strategies you'll see here. There are more strategies in our workforce areas because that was probably the largest concerns that we have. So you see more strategies here. So we want to also strengthen local workforce pipelines. One of the things we heard clearly is that, if we want to grow the rural healthcare workforce, we need to start in the rural areas, because those kids are likely to go off to school and come back home if that's where their families are. So you'll see funding strategies that we have for what's been called grow your own, or really looking at partnerships and mentorships and starting in middle school and high school to start teaching people about healthcare opportunities and what are the different places they can go to get trained, and then again to potentially return home. So working to at those younger ages to also have funding strategies around collaborative provider models. One of the things we heard from community members is that the while there are pockets where there's issues with finding a primary care, access to true specialty type services was really very limited. And what our rural providers told us is that in your rural areas, you just don't have there's not enough patients to support maybe a full or half-time specialist, whether that be a neurologist, an endocrinologist. And so what we're going to look to do with this initiatives is use a needs-based assessment to identify where those deserts are, so we can start to help build partnerships and think about how might providers in nearby areas collaborate to support the addition of those specialty services. We also know that in some parts of our state, there are people who there's a substantial wait or desert in terms of being able to access ambulance services. And so there are some promising practices around community paramedicine, tele services, and we're going to look at those, and we'll initially focus first on those areas that are in those more frontier areas, or far away from any local ambulance service. Oregon have deserts. I spoke with one parish the other day who told me they have one ambulance. And so if that one ambulance is in use, someone with an emergency may be waiting 2-3 hours while they try to bring somebody in from another parish. So we'll be looking at those and where we can make some expansions there. All right, next slide. Our next initiative is around sorry. Can you go to there you go. Modernizing technology infrastructure and capacity for efficiency and care coordination. So the state is looking to purchase what will be a state managed and CMS certified electronic health record instance. With the state having this license for this electronic health record, we would then be able to make available for our rural communities and rural provider agencies, we'd be able to make the electronic health record license available to them, along with providing maintenance and technical assistance and funding to help them shift from whatever the current system is that they're using to a different system. This will substantially then increase our ability to have more real-time measurements around outcome data, more interoperability across the different systems. For example, if you're in a rural area and you have a primary care, but you go out to a different area or a different facility for your specialty care services, if they use different electronic health records right now, they don't talk to each other. And therefore, sometimes there might be duplications in lab work or test. There might be times when we don't know all the medications folks are on because we don't have that interoperability. So we'll be looking to make investments and make improvements for folks when it comes to access to care and the data that we're able to collect. The grant also allowed us to use the funds to do something called a Rural Tech Catalyst Fund. We are still waiting additional guidance on this, but ideally, or in theory, what will happen is some of these funds will be invested in some way with other either donations or investments. And then from this fund, we would then be able to make what's called milestone-based grant opportunities, which means someone would apply. This is tied to potentially research, new opportunities around technology, looking at new initiatives, but we would then be able to use these funds for the chosen projects to then implement new technology and be able to study over time. How that, what the impacts are there. So again, more to come. This is one that we still are waiting on some additional guidance in terms of exactly how we can use it and what those investments look like. Okay, next slide. Also in technology, we plan to have, sorry, I'm waiting for the slide to go. I want to make sure I do it in the correct order. Can you go to the next slide? There we go. We want to expand access to and promote the use of remote monitoring devices. We've heard a lot of promising practices related to remote monitoring and use of remote monitoring, especially in our rural areas, because those folks are having to travel potentially further than others to be able to have access to care. And many of these remote, if not all of the remote monitoring right now, is not a billable service in our Medicaid system. There are some that are starting to be able to be billed in Medicare and private insurance, but we want to be able to have these strategies in place so that we can study those and then looked forward to, does it make sense for us to then begin to include it in the Medicaid schedule? I think I've jumped ahead if you want to go back one, just so folks have an opportunity to see that slide. The other investment in modernizing technology is around the digital health literacy. So one of the things the grant really talked about is forward facing or consumer facing technology so that we can think about that. We have been working with a partner who has begun being able to provide smartphones to our Medicaid recipients with the idea that in order to continue to receive that free or subsidized cell phone or smartphone, that there's certain apps that can be installed. There's a requirement that they use some of those apps on health literacy or health education in order to continue to maintain the phone. We can also work with also plan to work to identify more specialized literacy areas, whether that be high-risk moms who can have access to information there. It might be that we utilize a platform. We hear a lot about care navigators and our use of our community health workers in rural areas. So looking to use potentially technology to help build that. And so this platform will be used to help, again, the consumer or our rural residents themselves have better access to digital literacy and digital healthcare. Okay, now next slide. We also know that our rural hospitals and health clinics and FQHCs don't often have access to or the ability to participate in risk sharing agreements. And a lot of times that's because there's not the sophistication there to be able to collect the data that's needed to be able to look at these value-based arrangements or risk-sharing arrangements. And so we will be looking to build out uh, different payment models. If you're familiar with this language, CMS calls it alternative payment models. So, looking at alternative payment models or different ways that we pay our rural facility than what we do now, that does help them to take on some of the risk. And when you take on risk, and you have value based arrangements, what that means is if you're providing quality services for those rural residents, there are incentives built in if you are helping people be healthier, stay healthier, get healthier. And so want to make sure that our rural providers have access to those types of arrangements as well. We will also be looking at innovative care models. This is so one of the things that they said in the notice of funding opportunity is you cannot just use the funds to pay for things that are already in place. So, for example, if there's another grant available, like then you can't just use these funds to usurp it. If there is something that's being billed for in Medicaid, I can't just say I'm going to use these funds to pay a higher rate because they happen to be in a rural area so that we can attract that. But what they did say is if there are things that are not billable right now, then we can use these funds to fund those and then really do some research and study. Does it make sense for us to look at now adding them within Medicaid or making recommendations to others to add those services? So we will have opportunities for grants to really start to study some of those innovative care models and implementing them across the state. Okay, next slide. We will also, in the area of really starting to think now about chronic disease, helping people be just healthier, helping our rural Americans, our rural Louisianians be more healthy. We have strategies around expanding physical activity and nutritional interventions through community-based partnerships. We over the last few years, you may have heard a lot about food pharmacies or food as medicine. There's some different technology or different terminology that they use for that. But we'll be looking at rolling out some grant opportunities and really looking at working with our rural providers, working if there is an agricultural center there, working with that agricultural center, really helping people start to better understand healthy eating and how to get there. So we'll have opportunities for funding to roll those things out. We also will be supporting community-based nutrition and fitness. We know that in order to help, health disease, we needed a focus on prevention as well. And so this will help us expand that. Pennington Biomedical has done some great research and had some great activities there. We'll be looking to work with them as well as our well ahead within our Office of Public Health on where we can roll out some strategies that they've already started to study in this area. All right, next slide. Also, in the vein of helping to continue to think about how we help people be as help start to address some specific disease states. We will have funding. We know that there are see, we know that there are substantial care deserts in our rural communities when it comes to substance use treatment facilities. And we also know that there's a real benefit to folks to have their behavioral health and their substance use care together. So we will be looking at opportunities to expand behavioral health in our rural communities with an intentional focus on integrated care of the behavioral health and substance use treatment areas. We also know that there is great research and we've had great outcomes in Louisiana for seniors in the PACE centers, which is the program of all-inclusive care for the elderly. But we also know those right now are only in our urban areas. We do not have any satellite facilities of any kind in our rural areas. So we will be looking to make investments to help expand our alternate PACE sites into those rural areas. There are also promising practices around what folks call care convener networks. So we will have a grant opportunity to work with some care conveners, and that's pulling in a lot of folks within our network, starting from the schools to our health clinics and other areas, and pulling them together to think about how we start with a starting focus on our children. How do we start helping children in rural areas be more healthy and embedding that into the communities when it comes to, physical, behavioral, and social service help? So we will be looking at some grant opportunities to expand that. We also know that a lot of our rural areas don't have, we talk about the promising practices of telehealth and how telehealth can help, but there's a lot of infrastructure needs that go with being able to have telehealth in a community. And so we will be looking at different grant funding opportunities to see where we can increase our telehealth and telehealth infrastructure. All right, next slide. And then the final strategy I'll share with you guys, again, 20. So we got a big lots of plans with this funding. But the last one is we heard clearly from our rural facilities that most of the infrastructure itself a lot is typically older, and there's a need to have some investments made in capital improvements. This is one of those things where in the notice of funding opportunity, they had a lot of restrictions and guidelines around what you can or can't spend funds on. And it did say, for example, that you can do no new construction. So we know that we wouldn't be able to give funding for new construction. There is the ability to do some renovations, but then there's certain requirements tied around the ability to do renovations. So what we envision is opening this up as a competitive grant. We know there's a lot of need out there. We cannot spend more than 20% of the funds on this initiative. So we will have to take in applications and then making sure that the money stays under that 20%. But what we're looking for are folks who can tell us that they need capital improvements, but by doing these capital improvements, they are going to expand access in some way. It might be that they ask for grant funding to cover the cost of some new type of technology or diagnostic machine. And then we would then look at, is that diagnostic machine needed in that rural community to support a gap? And then we would look at the outcomes and how many more people would they potentially be able to serve with that piece of equipment. It might also be that there's a part of their hospital or clinic that is not being utilized that could be utilized to expand services. And so we would then, they could apply and tell us, with these capital improvement funds, we would then be able to now have this brand new service line that don't have available currently. So it still needs to focus. It's not just capital investments, but it's investments that will result in increased access for the communities. All right, next slide, please. Wanted to share with you guys as well a little bit of a snapshot. If you go to we do now have a rural health transformation landing webpage that has a lot of this information there. There is a link to our entire project narrative, so it'll give you the details of the information that I shared today. And in there, you will also see I mentioned, milestones. So it'll tell you we had to break it out into phase 0, 1, 2, 3, 4, and sort of give timelines for when we would accomplish each of those milestones. We also have targeted outcomes that we will be looking to impact. And we'll look at baseline data, and then we'll start to look at, 2, 3, 4, 5, all the way through the life cycle of the grant. And we're really looking to make substantial improvements in a lot of the areas around access. So we want to measure how far away, how far is it from where your primary care is, and can we start to make sure folks have access closer in their rural areas. Um, Looking at that specialty care and access there in certain areas. We'll be looking to make sure that the EMS response time for high acuity incidents is decreased. We'll want to make sure that rural providers are able to leverage data exchange for coordination of interoperable platforms. Be looking at other health markers and really starting to look at chronic disease. And again, this is just a snapshot. Look at participation in school-aged physical fitness programming. We know that the governor signed an executive order a few months ago requiring the Department of Health and the Department of Education to work on reinstituting the presidential physical fitness test across the state. So we'll be looking at activities there, knowing that health starts at a very young age. And again, looking at some more clinical improvements and clinical outcomes. We will be developing a dashboard that will show all of the outcome metrics that we identified in our grant application. Um, and again, will be transparent around that reporting. Anyone who does receive funding through these grants, through any of those 20 strategies that I just mentioned, will also be required to have outcomes or data metrics that they report on through the life of the grant opportunity or through the span of them receiving funding. So we will have, statewide targets that are similar to those that are here that we'll be able to pull out by parish, but we will also have reporting metrics for those receiving funding through the grant. All right, next slide. So our next steps are, and I guess prior to publishing, one of the things we need to do is first get that final approval from CMS. And as soon as we have final approval from CMS, we're preparing ourselves to be ready to quickly start publishing our notices. How do you apply? Where do you go to apply? Of those 20 strategies, they of course all won't roll out at the same time. There are some that we anticipate being able to make within a few weeks of us getting this final approval. There are some that'll take us longer to build. For example, we anticipate having the Rural Clinician Credit Bank open quickly. We anticipate the capital investment being open quickly, the Rural Hero, because we have the basis for those that should be easy to roll. But those alternative payment models that I talked about, we're going to need time to build those out and make sure we're doing it the right way. So you might see funding a little later for those before funding is open. So, but again, we also envision this not as, a lot of times when we talk about grants, if you've worked with grants, like some of the larger agencies have maybe a team of 3 or 4 folks who are assigned to grants who go look for opportunities, see where to apply. It's a very complicated process sometimes to apply, and even more complicated in terms of the reporting. Well, we want to make this as easy as possible. In order for it to work for our rural communities, we can't have this be a complicated system, and we can't expect them to go find it on our website. So we want to be able to be out. We want to be able to share with folks what's going on. It's why when you guys asked me to come speak, I'm trying to speak to as many people as I can so they know this is coming. But then once it gets here, we really will have more targeted, focused outreach on the specific initiatives that as they open to make sure anyone who might be eligible to apply knows about it and can go find it and apply for the funding so we can start to make a difference. We also expect the governor soon to come out with an executive order for a rural health transformation advisory group. I've had a lot of people express interest. I will let folks know if you are a person who may receive grant fundings or associated with an organization that may receive grant fundings, you can't be part of the advisory council because that's a conflict of interest. However, these will be quarterly meetings. They will be open to the public, and anyone from the public is happy to attend and be a part of these meetings. The main thing we will be doing is focusing on the quarterly reporting that goes to CMS. We plan to share that with this advisory group. We plan to, if things are working, not working, use them to bounce ideas around in terms of how we're thinking through things. And again, that advisory group will be there through the life cycle of the grant. We also will be establishing some regional groups. One of the really cool things I found when I did the community idea raisers, again, we only had three, but at all three of them, there would we said, "Hey, what do we need to focus on?" Someone in the audience stood up and said, "Hey, I already have this grant or this opportunity or this funding, and I don't have enough people that are asking to be a part of it." And then someone else would stand up and say, "Well, I know lots of people who could use that." And they started to make connections. And that wasn't anything that we did other than we established the right forum for people to start to talk to each other. So we'll be looking to do more of that and building more regional partnerships where we invite any interested parties in those communities to come together and think about how do we share resources, how do we use these funds combined with the other funds that are out there to start making a difference at the individual community level. I will be out and about. I plan to visit over the course of the next year every single rural area that we have and visit their hospitals, their health clinics, their FQHCs, any other healthcare facilities, but also really just having an opportunity to. I'm from Louisiana, lived here my whole life, but and have been all over, but I haven't spent time really getting to know each individual community. So would love to spend time doing that. And then again, as I said, we really want to get this information out. We will have as many public forums as we can to make sure folks know about these opportunities. Okay, next slide. And final slide. If you have questions, oh, I'm sorry, no, it's not. So as part of this grant, CMS also has required that they review all of the publications that we use. And so they've asked that we add the Stevens Amendment to let you know about the total funding that we received and to let you know that the content here is not representative of the official views or any endorsement by CMS or the US government. One more, now final slide. If you want to reach out to us, I think we will have time for some questions. But if you want to reach out to us or you have thoughts or suggestions, the email address is ruralhealthtransformation@la.gov. Right now, I am building a team. I will have we're established a new team to really oversee this grant. I am in the process of hiring. So right now it's just me on the team. So I don't have a lot of bandwidth to check that email constantly, but I am in the process of hiring some folks that'll come on board. But please don't hesitate to reach out to that email. We are collecting to be able to have like thinking about who our partners are, who do we need to talk to, what are the resources out there. So please don't hesitate to reach out to that. Just you won't get an immediate response, but again, we do plan to have engagement as we think about more outreach in the upcoming months. And then if you have questions, comments, feedback you would like to give CMS, that maharural@cms.hhs.gov is the website, I mean, the email address that they have set up that's dedicated to their rural health efforts. CMS also has a brand new office with a new director and deputy director for rural health. And so they are reading or receiving those emails for public as a means of public feedback. All right, so I will stop there, and I think we do still have time for questions if folks have questions for me.
Okay, thank you, Julie, for that great presentation. I'm gonna go ahead and start fielding some questions. So I see the first question from Anna Hardman. I understand that Louisiana will not use their typical procurement process due to timing. When do you anticipate grants slash RFAs will drop and who is eligible to apply? Rural systems or vendor point solutions?
Yeah, so there's lots of different ways to look at procurement. And it's hard when you say typical procurement. There's lots of different mechanisms for procurement. One of those mechanisms is a request for proposal. And here in our state, those typically take about 2 years to get through the process of an RFP. And then, uh, sometimes another year before you get to implementation. We are trying, if that's what you mean by typical procurement, we are trying not to use that mechanism because of the length of time, but we are looking at other ways that we can go through either partnerships or relationships or agreements with folks. So for each of those 20 funding strategies, it looks a little bit different in terms of how the funding comes out. As I said, it's a little bit different in terms of who might be eligible to apply for those funds, and then how that happens. Also the timing of it. So it's hard for me to give a timing. I will tell you that they will not all be released at the same time. There are some that uh, pending CMS approval and then pending our own internal approvals, because I'm not really able to, until I have the final CMS approval, I can't get my finals approvals to release information. So there's some bit of delays in terms of the timing. We are working to position ourselves to roll them out as quickly as possible. Um, Again, some of those strategies will come soon. Most of or many of the grant opportunities are trying to reach, we're trying to reach specifically our rural providers. And so I envision that the majority of those being through a rural provider. And doesn't the other issue is that if we work with one statewide vendor, there are some complications there. And we want to make sure that the what we're getting out, what we're using these grant funds for, are what's needed in those communities and something those communities are going to use. So I do envision the majority of those opportunities being through the rural facilities themselves. But again, that's not all. There are some other opportunities as well.
Sorry, realized I was on mute. This kind of answers a little bit of Denise's question, which was, do you have any more of an update on when you may receive the funds and the process will start for the proposals? So, do you have anything to add to that, Julie?
No, CMS is actively, I talk with them at least every other day. So I don't want to give the impression that we're not. We're talking sometimes every day, sometimes twice a day, sometimes 2 or 3 days. But we're talking and they're working through what we submitted to try to get us, if not all of the funds, some of the funds, but it's very difficult for me to give a timeline. They gave themselves a 30-day timeline from January 31st when we submitted it. So I would hope to hear back that at least some of the funds have been released before that 30 days is up.
Okay, thank you. And Regina asked, can I get a copy of this webinar? And this is for all attendees today. We will post a recording of today's webinar on our YouTube channel. And my colleague is going to drop a link to our YouTube channel. So y'all can have that on hand and to review the recording later. We have another question that asked, with 44 parishes designated rural and significant health disparities, how will local community voices be incorporated into funding decisions to ensure investments reflect each parish's specific needs?
Yes, I think that'll happen in a variety of ways. One of those ways is that we are planning to do a large uh, a a needs-based assessment or a gap analysis. You can call it different things, but something that will allow us to look at by community. You oftentimes hear people talk about food deserts or specialty care deserts or different things. Well, we envision having some data that will help us know by rural community, not just by parish, but by rural community. What are those deserts? Where are the issues? But not just using data. Data is a starting point for us, but we also, as I said, I'm hiring staff right now. Everybody who's applied, one of the first things I tell them in the interview questions is, we're not going to sit in Baton Rouge and run this grant opportunity. We're going to be out and about in rural communities. And so I am, as the executive director, invested in hearing directly from not just the providers, but also the communities. We've learned the communities are your pharmacies, your grocery stores, your local officials, your the people who live there who are receiving services. It's the whole communities. And so the way that we'll hear from you guys, we can't those initiatives that I gave you, those are the ones that we have to focus on that. So we do have some limitations in terms of being able to change the strategies or the initiatives, but thinking about how we might invest differently or what is really a need in that community, we definitely will learn more as the team starts to go out and meet with folks across the different communities. So I plan to do that by holding town hall meetings or community idea raisers or whatever you want to call it in those areas, and then making adjustments as we need to. So just because we make an investment in year one doesn't mean we don't need to switch and do something different if that's not working for a particular community, or learn, well, we didn't do this and we should have, so where do we need to potentially make tweaks? That to me is the interesting part about them only giving us 1 year at a time. It's kind of like you need to be hearing from people and then making those adjustments if you need to, based on what you're hearing and data showing you.
Got it. Thank you for that answer. And then we have a question from Edward, and he asked, what phased implementation strategy will Louisiana use to minimize service disruption during the transition to a unified EHR? And what predefined benchmarks would trigger a pause or recalibration of the rollout?
Yeah, so just to be clear, the department will not mandate that anyone use the electronic health record that the state will have to offer. It will be up to each individual facility, whether they wish to participate in the program or not. So just to be clear there. Um, we are right now developing some tools that we'll call readiness tools that can help a facility understand if they are ready, if they have the infrastructure needs, and if not, as I mentioned, there's some, whether that's that capital improvement, there's funds and grant opportunities available that might say, facility B is not ready yet, but here's some opportunities for grant funding that you can use to help get your facility ready. And then if again, once a facility decides, yes, they would like to participate, they've gone through and we've determined that readiness is available. The grant also includes the the training and technical assistance that's needed to get a facility from through migration and what that needs to look like. So there's opportunities. The facility won't be on their own. We won't say, congratulations, here's your license. There's also that technical assistance to help through that migration, through the training of the new system, and then implementation. So the we don't have all of the details of that worked out. We do have folks willing to partner with us who either understand electronic health records or understand from the facility perspective what's needed, we'll have a plan fully mapped out to help make sure that to the point, that there's not interruptions and that we're thinking through that migration piece.
Okay, thank you for your answer on that. So we have a minute until today's webinar ends, and so I just want to make a reminder to everyone to complete the post survey. That would really help us get feedback, and especially if you're getting CE credits, to complete it so you can receive your credits. As well as we dropped the link to the YouTube channel in the chat, and also the email that Julie had on her presentation. So if there's no any additional questions, I think we are done for today. Unless Julie, you have anything to add to your presentation.
Nope, thank you very much. And for those of you who are involved in the rural health space, I look forward to getting to know you and give me a couple of months, but please invite me to come visit your community.
Definitely. Thank you so much, Julie, and thank you so much, Alyssa, for your interpretation. Have a great day, everyone.